Dear students and viewer, we will be discussing today autonomic nervous system. What is autonomic nervous system? For that we should understand the general division. That is, division of the nervous system is divided into peripheral nervous system and central nervous system. And you know that central nervous system contains the brain and the spinal cord, whereas the peripheral division contains the autonomic nervous system, and also it comprises on the somatic nervous system. The autonomic nervous system is then divided into sympathetic nervous system and the parasympathetic nervous system, and you are quite familiar with this division. This is general layout that how the autonomic nervous system is interlinked, and how these different subdivisions work together. It is a technical point to remember that this is for the better understanding of the students. We have classified that, or the scientists have classified this likely in the manner. However, all these systems work together as a composite nervous system to maintain the normal physiological function. Now, this is a classical diagram you can find elsewhere in the books, any books of pharmacology or physiology. So this is the medullary region, and this is the spinal cord, you see, and the nerves are originating from it. From this cranial region, you see the medullary, there is the craniosacral division from the cranium, and the sacrum, you see the preganglionic nerve is long, there is ganglia in between, and then the postganglionic nerve is short, whereas at the postganglionic level this is going to release the acetylcholine, where the receptor is muscarinic, and this is parasympathetic division of the autonomic nervous system. Regarding sympathetic division, you see the preganglionic nerve fibers are very short, and there is ganglia in between, likely in the parasympathetic division. And interestingly, here also the receptor is nicotinic, like here, and the neurotransmitter is acetylcholine in all the ganglia. In case of adrenal gland, which is present at the top of the kidney, you see this is adrenal medulla, and this is cortex. In different books, the cortex is not displayed here because they merely stress on the release of norepinephrine and epinephrine from the adrenal medulla, that is with the ratio of 20, ratio 80 respectively. But I have drawn a circular of a cortex region here and just mentioned that adrenal cortex secretes cortisol, because this cortisol is having a close relationship with the stress and the sympathetic division of the autonomic nervous system, where the negative feedback fails on stress and the role of cortisol. We have already uploaded a short video on YouTube. You can then take the support of that video, that how cortisol is going to affect the autonomic nervous system pharmacology and the diurnal pattern. But let me refresh your knowledge, that is that cortisols increasing the sensitivity of the myocardium add blood vessels to epinephrine and norepinephrine. Thus, cortisol and this epinephrine and norepinephrine work in close liaison, where sensitivity of the myocardium and the blood vessel is increased toward the catecholamine, and you know the role of catecholamine very well. Now, what happens when there is, you see, as a rule of thumb, in all the ganglia, whether that is a parasympathetic division or of sympathetic division, at the level of ganglia, the receptors are nicotinic and the neurotransmitters are acetylcholine, irrespective of the type of the division of the autonomic nervous system, whether that is parasympathetic division or sympathetic division, you see. So here at the ganglia level, the neurotransmitter and the type of receptor is the same, which is respectively acetylcholine and nicotinic receptors. Scientists consider adrenal gland as a gland and not as a ganglia, because in ganglia, you see, usually there is preganglionic nerve fiber, there is synapse, and then there is a postganglionic nerve fiber. Here there is no, in case of ganglia, no postganglionic nerve fiber, so there, and it secretes the norepinephrine and epinephrine as I referred to earlier. Therefore, the most strong versus in favor of this adrenal gland to be considered as a gland is that's because of no postganglionic nerve fiber, like in case of parasympathetic division and sympathetic division of the autonomic nervous system. Interestingly, what happened at the post ganglionic nerve ending? So in case of parasympathetic division, the neurotransmitter is acetylcholine and receptor is muscarinic. Here in case of sympathetic division, the neurotransmitter is, in case of sweat gland, this is a special case where the neurotransmitter is acetylcholine and the receptor is muscarinic. Had it here been the neurotransmitter as a norepinephrine, here the situation would have been totally different, like it is related to the sweating, and had it here norepinephrine, so sweating phenomena would have been stopped, and once the sweating phenomena stops, then your body temperature will rise, because it is in case of sympathetic division of the autonomic nervous system where the metabolism is high, where the body is in need of energy, as it is in fight and fight and flight mechanism. Therefore God is the biggest scientist, and he created sweat gland with the acetylcholine and muscarinic receptor at the postganglionic nerve fiber ending of the sympathetic division, and thus to help in body temperature regulations. Now, in case of sympathetic division of the autonomic nervous system, you see there is norepinephrine at the adrenergic nerve ending, where the receptor may be alpha or beta, and this is classical example of this is cardiac and smooth muscles. In case of kidney and renal vascular blood smooth muscles, so you see the receptor here is dopaminergic and the neurotransmitter is dopamine. This is the beauty of God again. Had it here been norepinephrine, and you know norepinephrine has alpha effects and beta effects. So if alpha effect had norepinephrine here, so because of the alpha effect there would have been renal ischemia and ultimate renal impairment. So dopamine here will increase the renal perfusions. Thus it will not only help in the management of shock, but will also then promote renal perfusion, which is the need in most of the cases while managing shock, or post-traumatic shock or post-operative shock. Let me proceed to the next slide. Now, as you know, there is a nerve and there is a nerve endings. There is effector organ here. In case I have just merely for better understanding drawn a model of heart. So it is a nerve ending, and nerve ending here with the heart having its receptor on its myocardium. You see, I have just made this area amplified or zoomed it, and if you zoom it, you will find it here. This is the nerve endings, and this is the portion of this myocardium. You see. Now what happens? So first understand this the events happening at the level of adrenergic nerve ending. Here is the tyrosine is an amino acid that is uptaken into the nerve endings through the active transport phenomena. Then it is converted into dopa. Dopa is converted into dopamine, and due to decarboxylase enzyme, carbon dioxide is removed and it is converted into amine dopamine, and dopamine is then converted into norepinephrine. And this norepinephrine I have drawn with a structure of a triangle. You see, and these are the neurotransmitters. Now these are the neurotransmitter, and then they are stored in the vesicles. You see here are vesicle and they are stored. Now when an electric stimulus or impulse arises here, so it fuses the vesicle, and then the norepinephrine are released into this synapse. These gaps are called synapses. Now in this synapse, you see there is a release of the norepinephrine, and this norepinephrine now comes at the this is postsynaptic membrane of the effector organ. Here the effector organ is heart, as I have taken a model of heart here. Now what happens? So it have the receptor, beta 1 receptor. You know, heart is having predominantly the beta 1 receptors. So this norepinephrine will now come and attach with the beta 1 receptor, as it is going to have affinity, specificity, and intrinsic activity. Now the key characteristic, as you know, as I said too, that it is affinity, specificity, and intrinsic activity. So norepinephrine is having affinity for this beta 1 receptor. It is specific for this beta 1 receptor, keeping in view the key and log theory system. And intrinsic activity means that the secondary messenger system of this receptor is then activated. Now the secondary messenger system of this receptor is that since it is a nerve cell and Krebs cycle is there, ATPs has already generated through the glycolysis. Now this ATP will be converted into cyclic AMP. But how it is converted? It is converted through the adenylyl cyclase stimulation, and then cyclic AMP is increased, and this cyclic AMP will then promote the influx of calcium inside the cytosol. And what will happen? There is alpha receptor, and these receptors work together. So stimulating the alpha receptor, alpha 1 receptor here, you see, will stimulate the phosphoinositides, and then it is converted into inositol triphosphate diacylglycerol. Diacylglycerol will activate the protein kinase C, whereas inositol triphosphate will help to release the calcium from the internal store like endoplasmic reticulum. Now releasing of calcium from this endoplasmic reticulum will lead to an increase in the calcium, as it works together in conjunction with the influx of calcium from the extracellular to the interior of the cell. So this increased surge in calcium and this release of calcium from the internal stool will lead to ultimate increase in the calcium level. Thus it phosphorylates the protein, and phosphorylation of this myofibril of the heart muscle will lead to increase in the force of contraction, and increasing the heart muscle contraction will lead to a positive inotropic response. There is increase in the conduction, that is positive dromotropic effect, and increasing the heart rate. So the ultimate overall effect is increase in the cardiac output, increasing the heart rate, and thus blood pressure will rise. So this is how this nerve endings will work. Now this is the whole phenomena. You can play with this. How you can play with this? If we understand this presynaptic mechanism as, so you see, through, as I said, through the exocytosis phenomena, once this norepinephrine release and it promotes the rate of forward reaction and the intrinsic response or the pharmacological response, as I did discuss here now. So it has to be regulated as well. How it is regulated? That in the synapse there is catechol O methyltransferase enzyme, and when the level of norepinephrine is high at the level of synapse, so catechol O methyltransferase enzyme will come. It will convert its norepinephrine into anectoform, and thus the level of the norepinephrine at the synapse is regulated. More, if the level is high, it will give a response to these presynaptic alpha 2 receptors. Now this norepinephrine come and attach with this presynaptic alpha 2 receptor. Now interestingly, the presynaptic alpha 2 receptors are having adenylyl cyclase system, but it is coupled with G ligand G protein or G protein, inhibitory protein, that will have stimulation of this receptor will have a negative effect through the inhibitory ligand G protein, and then then the release of norepinephrine into the synapse is decreased. So stimulation or agonistic activity of alpha 2 will lead to a decrease in norepinephrine, and antagonistic activity of presynaptic alpha 2 receptor will have the opposite action, that there is increasing the norepinephrine at the synapse. Now coming on this side, there is reuptake mechanism, and this reuptake mechanism means that once the level of norepinephrine is high at the synapse, so it will be reuptake through the reuptake 1 into the presynaptic nerve endings, and this is the presynaptic nerve endings where now this free norepinephrine are here. Now there is another enzyme, that monoamine oxidase enzyme, and this monoamine oxidase enzyme will oxidize this norepinephrine into inactive form. Thus you can play here as well. If we inhibit this monoamine oxidase enzyme, so it is going to increase this free level of norepinephrine, which will ultimately promote the rate of forward reaction, and that is exocytosis. Now, as I did discuss, inhibition at this stage of the reuptake will lead to an increase in the synapse level. Thus, drugs like cocaine and tricyclic antidepressants will increase the level of norepinephrine in the synapses. Therefore, these drugs carry a potential risk of hypertension or increasing blood pressure as a peripheral effect, though these drugs are used at the level of central nervous system. And though we are discussing this at the level of peripheral nervous system, yet drugs are blind, and that carries and may reach and work at the central nervous system. And working at the central nervous system, you see, tricyclic antidepressant will also work at the peripheral nervous system, and then that carries the risk of sympathomimetic activity, which will appear as an adverse effect of the TCA, tricyclic antidepressants. Now, as I discussed, so cocaine and tricyclic antidepressant will increase the level of norepinephrine at the synapse. Similarly, if we inhibit the phosphodiesterase enzyme here, the cyclic AMP level will be increased, and increasing the cyclic AMP will increase the calcium level. So, to summarize that effects, the previous effects, you see, all these effects happening at the level of postsynaptic nerve ending. Here, this is in a case of myocardium that I have taken. So I have further zoomed this region, you see, just for understanding of dopamine or inotropic drug response. So what happens in case of inotropic? This is if this double line is the myocardium. So there exists the sodium-potassium ATPase system, and this sodium-potassium ATPase system just produces normally in the absence of drugs like digoxin. In the absence means without digoxin. So what is the action? That potassium comes inside and the sodium goes outside. Now, what happens if we block this with digoxin? And if we block this with digoxin, so this normal phenomena won't happen. Now, the sodium will not exchange for the influx of potassium. So, consequently, the sodium level will rise here at the intracellular or cytosolic sodium level will rise. Now, this raised sodium will exchange with this ion exchange channel. It will go to the exterior by following this ion exchange mechanism, but as an exchange, calcium re-entry will happen, or calcium influx will happen, and calcium influx is what happens, so calcium level is increased. And once the calcium level is increased, this will lead to a positive inotropic response. And how that is triggered, you see here are at the myocardium the beta-1 receptor, as I discussed in the previous slide. So beta-1 receptor, now norepinephrine. In addition to norepinephrine, I have mentioned here epinephrine, I have mentioned dobutamine, dopamine. All these are inotropic drugs, so they will come and attach with beta-1 receptor, will thus stimulate, have a positive effect on the adenylyl cyclase enzyme, and stimulating the adenylyl cyclase will lead to the conversion of ATP into the cyclic AMP. From where the ATP comes? ATP comes from the Krebs cycles that already been prepared in every cell. Now the cyclic AMP level will promote the influx of calcium through the voltage-gated calcium channels, which I have not mentioned here. So what happens? Consequently, the calcium level rises, and once the calcium level rises, so it will give you an inotropic response. Now there is another technical point, that if there is an enzyme phosphodiesterase, and if you inhibit this enzyme, so what will happen? Cyclic AMP will not be converted into 5-AMP. 5-AMP is excuse me, inactive, and once this is inactive, so it will thus help in regulation of this reaction, but it become inactive due to the action of phosphodiesterase enzyme. Now if you block this phosphodiesterase enzyme, what will happen? The level of cyclic AMP will rise, and once the level of cyclic AMP rises, so it will produce an inotropic response through the influx of calcium. So the calcium level rises, and all these will contribute. So inotropic drugs, that will increase the cardiac output. How? By increasing the force of contraction of the myocardium, and thus these are very good drugs in the management of shocks and other clinical conditions as well. Now, in a nutshell, what happens to the cardiovascular system now? As the heart contains beta-1 receptor that we did discuss in the previous slides, so stimulation of which will lead to increasing the heart rate, increasing the force of contraction of myocardium, increasing the automaticity, increasing the conduction velocity, that is positive dromotropic effect. Consequently, what happens? The blood pressure will rise. How the blood pressure rises? As the peripheral resistance is increases. Why the peripheral resistance increases? Because of the alpha receptors and the blood vessels, the release of calcium is promoted. So peripheral resistance will rises, and you will understand now in the next slide. The heart rate is increased because of positive chronotropic effect, and the stroke volume because of force of contraction of the myocardium, or due to the positive inotropic response, this is increased. So consequently, blood pressure rises. Now, effect of the norepinephrine on the blood vessels, artery and arteriole. It is an important point to remember that peripheral resistance is mainly due to is contributed by the blood vessel of viscera and cutaneous. So visceral and cutaneous blood vessel contains alpha receptor, especially alpha 1, and constriction of alpha 1 receptors both in the visceral and cutaneous blood vessel will lead to the narrowness of the lumen of these blood vessels, and narrowness of the lumen of these blood vessels will lead to increase in force on the wall of the capillaries, and increasing force on the wall of capillary mean increasing force per unit area, and increasing force per unit area mean this is mathematically equal to pressure. So the pressure exerted by the blood on the wall of capillary will be called as blood pressure. Thus alpha 1 receptor stimulation will increase the force exerted by the blood on the wall of the capillary. Thus stimulation of alpha 1 receptor will lead to increase in blood pressure. Rest of the receptors and action is self-explanatory. Now here is I have system-wise effects of the sympathetic division of the autonomic nervous system. In GIT, in the sphincters, there is alpha 1 receptor, and contraction of sphincter will lead to control on certain phenomena. The splenic capsule is if contracted because of the stimulation of the alpha receptor, so it will squeeze, and once it will squeeze, so it will shift the blood. Spleen is a reservoir of blood. It will shift the blood into the general circulation, and shifting the blood into the general circulation will help you prepare for the fight and flight mechanism. That sympathetic nervous system is known by the fight and flight mechanism, whereas the parasympathetic nervous system is known by the rest and digest mechanism, or digest and rest mechanism. So here we are discussing the sympathetic division of the autonomic nervous system. What happened to urinary bladder? The detrusor muscle are dilated, so accommodation for urine will be increased. whereas the sphincters have alpha 1 receptors, so contraction of the sphincter will help you to retention of urine, which is needed because because the person is in flight and fight mechanism. Excuse me. In case of lungs, there are beta 2 receptors, and stimulation of which will lead dilation, and this bronchodilation will promote the more oxygenation phenomena as a person is in fight and flight mechanism, or the BMR is high as he is performing physiological action on high rates. Uterus will have beta 2 receptor, so it will produce relaxation. In case of gravity uterus, these alpha 1 receptors, so it will contribute to the contraction. This is important, especially glycogenolysis effect or effect on the metabolism. You see, the skeletal muscles will have beta 2 receptors. Skeletal muscle will have beta 2 receptors. Thus, the glycogenolysis from the skeletal muscle is increased, meaning the breakdown of the glucose is increased. From the liver to the alpha 1 and beta 2 receptor, again this glycogenolysis is also increased. Thus, it will produce hyperglycemia. So sympathetic nervous system stimulation will produce hyperglycemia. That will meet your body energy demand. As I am always referring to, it is fight and flight mechanism because it requires energy. And lipolysis is promoted through the stimulation of beta 3 receptor. So lipolysis increase, and this is an important point, where from the juxtaglomerular complex to the macula-densa region, renin is released, and renin is a positive vasoactive peptide, and renin will lead to, through the renin aldosterone system, will lead to sodium and water retention. Renin will convert angiotensinogen into angiotensinogen 1, and angiotensinogen 1 is converted into angiotensinogen 2, which is again a powerful vasoactive peptide. Thus, stimulation of sympathetic division of the autonomic nervous system will lead to increase in renin and increasing the angiotensinogen 2, angiotensin 2, which will produce a major rise in blood pressure. Here there is hyperglycemia, so the overall effect is very catastrophic, especially if your patient is suffering from stress as well. And on stress, I have uploaded a separate video where the negative feedback fails, and once the negative feedback fails, there is persistent secretion of cortisol through the persistent secretion of ACTH, and you know, cortisol are steroidal in nature, and it is converted into cortisone and other steroidal derivative hormones, so they are diabetogenic as well. And here the sympathetic division of the autonomic nervous system through the promotion of glycolysis through these beta 2 receptor and alpha 1 and beta 2 receptor in skeletal muscle and respectively in liver will also promote hyperglycemia. So never give stress to people, as Prophet Muhammad said that meeti baat bhi sadqa hai. So you see, which meaning that in English is that we should always be polite and courteous while talking to others. So we should use very soft and polite language. Never give stress to others. This is the message. Now, regarding insulin secretion is decreased due to stimulation of alpha 2 receptors. So insulin secretion is decreased, glucagon release is increased, and this is an interesting phenomenon. Now cortisol level is also increased. So if your patient is also in stress with this materialistic world, so hyperglycemia now will be very high and the patient may become diabetic. Now this slide describes the priorities of certain drugs and neurotransmitters on the alpha 1, alpha 2, beta 1, beta 2 and beta 3 receptor, where adrenaline response is equal to or greater than noradrenaline and isoprenaline for alpha 1 receptor, and for alpha 2 this response is like adrenaline response is equal to the noradrenaline, and isoprenaline is ineffective here in case of alpha 2 receptor. So same is true for likely in the manner as it is presented here for other receptors. In this this diagram we have discussed that various agonist and antagonist and the G protein, quantal protein. Here in case of alpha 1 receptor, the agonist work how? It involves the G quantal protein, and what it does, that increases the phospholipase C, stimulate the phospholipase C and D and phospholipase A2 and the calcium channel. Thus it produces its physiological or pharmacological response, and the order of priority of adrenaline response is equal to or greater than noradrenaline, which is equal to or greater than isoprenaline for alpha receptor, and for alpha 2 receptor adrenaline response is equal to or greater than noradrenaline and isoprenaline. Clonidine is an agonist of alpha 2 receptor, whereas yohimbine is an agonist of alpha 2 receptor. Similarly, antagonist for beta 1 receptor is metoprolol, atenolol, and for beta 2 receptor is butoxamine, and for beta 3 the drug has not been yet marketed, it is still under investigation. So what is important? Important is that the different secondary messenger system are involved through working through the quantal protein or inhibitory protein or stimulatory protein, and thus it produces its pharmacological or physiological response, as we did discuss in case of beta 1 receptors in the previous slides. I hope now you understand that. Thank you.